Just going to share the slides. Okay, right. Can you see this? Everyone see the slides?
Yes, we can.
Okay, great. Okay, we'll get started. Just going to get the right chat box out. Okay, great. So for those who've not attended one of my talks before, so the way I do it is I try to make this interactive. Essentially, I do a few of these tour of ECGs, and each one has a theme. Okay, and I'm a cardiologist and electrophysiologist. That means that I'm interested in heart rhythm, and I treat heart rhythm specifically as my subspecialty interest. And so when I go through ECGs, the main thing I try to teach you is just using ECGs to try and work out what heart rhythm the patient has. And we talk a little bit about, along with that, management of the relevant heart rhythm abnormalities. Okay, so previously when I did a talk, I think it was a couple of months ago, I spoke about tachycardia then. All right, so today we're going to slow down and talk about bradycardia. And the format is very much, I'll show you some ECGs, I'll give you a minute or so to look at it, to scrutinize it. I invite you to type in the chat box what you think the ECG shows, and then we do some teaching on the basis of that ECG. Okay, great. So let's carry on. So the first one is this. I'm going to just make it a little bit bigger. Okay, right. So we start with this ECG, and just to warm you up, and I'm going to give you a minute starting now. So I've got my watch here. Okay, you have a minute. Just type the answer, and let's see what you think this shows. Okay, some of the answers are starting to come in now. I give you another 30 seconds. Okay, I think, in fact, you probably don't need a full minute. I think most of you have actually put the correct answer in here. So, yeah, so pretty much, well, most of you put down sinus bradycardia, and that is correct. So, and some of you also mentioned that the ECG is otherwise within normal limits, and that's also correct. Obviously, when we mention bradycardia, bradycardia just means slow heart rhythm, right? Slow heart rate even. Bradycardia means slow heart rate. And you can have slow heart rate in normal rhythm, and that's called sinus bradycardia. Okay, and I'm sure you guys know how to measure heart rate. So you can see here, if you look at the sort of big squares, it's 1, 2, 3, 4, 5, 6. So it's just over 6 big squares. So that's around 50 beats per minute. So normal heart rate, as you know, is, and when we talk about normal heart rate, we mean obviously resting heart rate. And in general, normal values we give for resting heart rate is between 60 to 100 beats per minute. So anything less than 60 beats per minute is counted as bradycardia. So this is sinus bradycardia. You can see it's sinus because there's a P wave followed by a QRS complex, and the ECG is otherwise within normal limits, other than the fact that the heart rate is under 60. So sinus bradycardia. Okay, right. So interestingly, this patient also happened to have a Holter monitor. So I'm sure a lot of you, so this is a patient who've had, you can see here, the indication frequent falls, palpitations, and shortness of breath. Okay, so this patient had frequent falls, palpitations, shortness of breath. And the patient had a 24-hour Holter monitor. Okay, and this is the finding. It says here sinus rhythm. Okay, heart rate varies between 46 to 104 beats per minute. So this is within the 24-hour period of monitoring. And there are these ×4 short nocturnal episodes of sinus bradycardia. Okay, the slowest rate is 43 beats per minute for 6 beats. Rare atrial ectopics, no symptoms reported. So this is a Holter monitor, and I'm sure a lot of you have come across this before, and you may have come across a similar report to this. Okay, and her resting ECG is the sinus bradycardia that you see. So before we go further about talking about bradycardia itself, it's worth reminding ourselves what we're seeing on the ECG and what that relates to the actual electrical activity of the heart. So I'm going to zoom out a little bit here so you can see this. Hopefully you can all see this. I'm just going to. Okay, so you can hopefully all see this. Now, I'm just going to move this a bit around. So, okay, good. So here we've got on the top left corner here a cartoon of the heart, and at the bottom here one sinus beat, okay, with all the relevant waveforms. So what we're looking at here is the main structures involved in terms of the conduction of electrical activity during a sinus beat, okay, from the atrium to the ventricle. And I'm going to quickly go through those two slides I was talking about. So I was just saying that, you guys got the right answer, that this was sinus bradycardia, that this is normal rhythm of the heart, it's sinus rhythm. The ECG is otherwise normal, but the heart rate is under 60 beats per minute. So normal heart rate, I was telling you, obviously, as you know, is between 60 to 100 at rest. And so this is closer to 50 beats per minute, and therefore it's sinus bradycardia. And I was showing you this slide, I was telling you about this lady with that ECG had a Holter monitor, and I was going through this finding with you. You can see the indications here: frequent falls, palpitation, shortness of breath. You can see that sinus rhythm, heart rates between 46 to 104, with some nocturnal episodes of sinus bradycardia. Okay, so you may have come across a Holter result like this before, and I was telling you about. I then said we need to take a step back and have a look and see how that represents electrical activity of the heart. And I was just showing you this diagram, and I was just, as you know, this shows one sinus beat. As you know, sinus beats originate from the sinoatrial node, and the P wave represents atrial depolarization. And then what happens is that the electrical activity, the electrical signals then reaches the AV node, and the AV node then relates the electrical activity down the His-Purkinje system, leading to ventricular depolarization. And the time it takes from the start of atrial depolarization to the start of ventricular depolarization is also known as the PQ or the PR interval, okay? And so you know all about this. So what we're talking about when we talk about bradycardia, sinus bradycardia even, when we talk about sinus bradycardia, we're talking about the rate of sinoatrial node activity, the rate of depolarization of the SA node, okay? And remember that Holter I showed you earlier. So this is basically the heart rate tracing of this patient, and you can see that this is over a 24-hour period. So it is useful whenever you look at Holter monitors. There often is a page where it shows you this kind of, displays this kind of information. I'm going to zoom in a little bit. You can see that it is over a 24-hour period, and you can see this is during the daytime. You can see because the average heart rate during the daytime is higher. Can you see? That's the average heart rate during the daytime, and that's the average heart rate during the nighttime. So it's not uncommon to see this variation in the heart rate. All right, where the daytime heart rate is higher, the nighttime heart rate is lower. So can anyone tell me what determines the sort of heart rate change? So what do you think is a big determinant? Why is the heart rate in daytime higher than the heart rate in the night? So I'm gonna give you say 30 seconds, if you can put down the answer. That lets me know as well that you're able to hear what I'm saying and respond in the chat box. So I've got some answer back now. All right, people have put down physical activity, struggling physical activity, high metabolism, cortisol secretion. Okay, lots of interesting answer. Okay, so a lot of what you say, for example, the cortisol secretion activity, all these things are obviously, there are reasons why the sinus rate will increase, okay? But there's a kind of what I call the final common pathway, how these things act. And that's called the autonomic nervous system, okay? I'm sure you guys know what the autonomic nervous system is. And essentially, the autonomic tone determines a lot what the SA node activity is and what the heart rate is. And I want you to remember this concept of the autonomic tone, because we're going to talk a little bit. There are ways, obviously, that you can modulate autonomic tone, and we're going to talk a bit more about it afterwards, okay? Right. So I've got a second ECG now. So I'll give you a minute again. Let me know what you think of this ECG. Okay. So some answers are coming. Okay, I'll give you another 15 seconds. Okay, I think most of you got it. So most of you have put down first degree block or first degree heart block or first degree AV block, okay? Someone has put down, Victor has put down a very nice comprehensive answer that covers everything. He says, sinus rhythm, prolonged PR interval, heart rate 75 beats per minute, first degree AV block. Very good. So that is essentially what it is, okay? So this is sinus rhythm. It's sinus rhythm because essentially anytime you see P wave followed by QRS complex, when you see this sort of repeating pattern of P wave followed by QRS complex, 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 a sinus P wave specifically, then what you're dealing with is sinus rhythm. Okay, so this is sinus rhythm. You've all, absolutely, those who mention it, it's absolutely correct. The PR interval is prolonged. And the heart rate, in fact, is normal. It's not tachycardic, it's not bradycardic. It's within. So if you can actually measure it out, 1, 2, 3, 4. It's between 4 and 5. Big square, so it's anywhere between, so sort of say around 60 to 70 beats per minute, and you can basically see that there's nothing else significantly abnormal with it. So right, so when we talk about PR interval, what is normal PR interval then? Does anyone want to put it on the chat box? So anyone at all? Okay, so normally there's a range. Yes, okay, good. So it's between 3 to 5 small squares, absolutely. Okay, thank you, Tamika. So those of you who put down 0.12 milliseconds, that's correct. 0.12 is basically 3 small squares. So it depends on how you think. You can think in terms of small squares, you can think in terms of seconds or milliseconds. They all mean the same thing, okay? Each small square, as you know, is 40 milliseconds. So 3 small squares is the same as 120 milliseconds or 0.12 seconds, okay? So it ranges normal, by definition, ranges from 3 to 5 small squares, which is the same as 120 to 200 milliseconds, or 0.12 to 0.2 seconds. Okay, good. So you can see that in this case, look, it's very clear. So you pick any particular trace that you want here. I always like to look at V1 because V1 is very good at looking sinus P waves. V1 or lead 2 is good as well. So look at V1, okay? So you can see where the P waves are, and you can see where the QRS complex are. So this is basically sinus rhythm because there's a QRS complex following each P wave, right? Then you drop the calipers, okay, from the start of the P to the start of the QRS complex, and you measure it. So here it is measuring 320 milliseconds. So this is sinus rhythm with first degree heart block. Good. So I give you another minute to look at this. What is this rhythm? What is this rhythm? Okay, so someone has said sinus rhythm. Does everyone agree? Oh, right. Now, this trace, this is getting interesting because we're getting lots of different answers. So far, all the answers are different. So that means that this is good. That means that, you know, I'm probing what you know, and so we've come to a trace which is a little bit more challenging for you. That's good. Some of you probably still want to have a bit longer to look at this, so don't worry, take your time. Okay. All right, I'll give you another 15 seconds. Okay. I think most of you who are going to give an answer have given an answer. I think that's about, for my clock, about 1 minute. All right. So, okay, there are lots of different answers given, okay? Pretty much the whole range of possible answers have been given. The first thing I want to address, actually, before I do that, I'll tell you what, why don't we just go through this trace systematically, okay? I think it's always useful when you look at a trace like this to pick, you know, here I'm just going to concentrate on this particular segment first, because it's easier for me to go through the traces. So I'm just going to pick on this particular segment first, okay? So I'm going to blow it up. So now you can see it blown up, okay, blown up. So the first thing you've got to do, I've really kind of alluded to the kind of thought process in terms of determining a rhythm. Remember I said earlier, the first thing you need to do is to look for P waves, to see, you know, and see if these are sinus P waves. So indeed, remember this is lead 2 we're looking at. And indeed, you can see P waves, can't you? Okay. The P waves in this case is in blue, by the way, yeah? P waves is in blue. Can you see the P waves? Blue meaning blue arrow, I mean, okay? You can see the blue arrow showing you the P waves, okay? Now, when you see P waves, very clear P waves, you know for sure that you cannot be dealing with atrial fibrillation, okay? It's not possible to have clear P waves in atrial fibrillation. So it's clearly not atrial fibrillation, okay? Right. So these P waves are sinus P waves, okay? The next thing you need to determine is how does the P wave relate to a QRS complex? And so that's where my red arrow comes. Can you see my red arrow, which I put down here? See the red arrows? Okay. Now, so you can see, in fact, so what you're going to try and determine now that you've put the, you know, you've basically pointed out where the P wave is with the blue arrow and the QRS complex in the red arrow, you need to see what kind of relationship is there between the P wave and the QRS complex, okay? And you can see that initially there is a one-to-one relationship. So initially each QRS complex follows a P wave, but then there is a drop beat. Drop beats meaning that one of the P waves, so the first beat here in this trace is followed by a QRS complex. The second beat is followed by a QRS complex, but the third beat isn't. It's not conducted. We call it dropped, okay? So this P wave is not conducted to the QRS complex. And then you see again, resumption again of sort of P QRS, P QRS, P dropped, and then repeating itself again, okay? And one other thing you can also see is, in fact, the relationship. If you look at it here I've basically measured out the PR interval when the beats are conducted. You can see that there is a prolonging PR interval prior to the drop beat. So essentially the PR interval lengthens and then one beat is non-conducted. It lengthens and then one beat is non-conducted and it repeats itself, okay? So this is indeed called Wenke back. Oh, someone said they can't hear. Sorry about that. Maybe it's my microphone. Let me just find. Can you hear me now? Okay. Niraj, can you hear me? There's someone that said he can't hear. Okay, most of the other people can. Okay, I'll take. Okay, good. Thank you. So, so I was just saying that this is Wenke back. Okay, also known as second-degree Mobitz type 1 heart block. Okay, so for those of you who put down second-degree, yes, you are correct. But it's good that you are more precise and you can say that this is in fact Mobitz type 1, second-degree Mobitz type 1, and we also call it Wenke back. Okay. Now, if I go back to the original trace, I hope that it makes sense now. So if you look at this original trace, so I basically just enlarged this section because it's easier to go through a smaller segment. But if you look at all of this, in fact, you can see here, for example, the beginning trace, there's prolongation of PR interval and then drop, prolongation of PR interval and then drop, prolongation of PR interval and then drop. it repeats itself. Okay, you can see there are these clustered beats here. That's quite a typical pattern. And so this is Wenky back. All right, good. Now I'm going to go back to this original figure that I showed you right at the beginning. Remember I said this? I said that, you might remember, I'm going to zoom out a little bit so you can see the whole of the diagram. So earlier we were talking about sinus bradycardia, weren't we? And when we were talking about sinus bradycardia, I mentioned to you about how sinus rate is determined by the activity of the SA node, because that determines the rate of SA node firing. Sorry, because the rate of SA node firing determines the rate of atrial depolarization, determines the sinus rate. And I told you that, I showed you the Halter, and I told you that the autonomic nervous system is a big determinant on the heart rate. Okay. Now, when we talk about the PR interval, we're talking about a second element of conduction here. We're talking about the AV node now. Okay, because a large determinant of this PR interval, this atrial ventricular delay, because that's what the PR interval is. The PR interval is the time it takes from atrial depolarization to the start of ventricular depolarization. And a lot of that delay is due to delay as the electricity passes through this structure called the AV node. Okay, so it is worth for us to have a closer look at the AV node. What are we talking about when we talk about AV conduction, right? The AV node is here in blue. But in fact, if you look at it, obviously I was mentioning that a large determinant is conduction slowing down the AV node. But this whole junction of the heart, you have the AV node, and you also have more distally something called bundle of His, okay? When we talk about effects of the autonomic nervous system, I'm going to just zoom out a little bit here. I've drawn a line here, okay? Because anything above this line, so we're talking about the SA node and the AV node, there's a very big determinant from the autonomic nervous system in terms of how it influences the electrical activity and the electrical conduction. Okay, so again, this harks back to what I was saying about how periods of wakefulness, activity, stress, all these things, how that increases the heart rate, that's really by the autonomic nervous system. And the autonomic nervous system can also impact the AV node conduction, and that can also vary the PR interval. Okay, so I'm going to just show you a Halter trace. Okay, so this is another Halter trace, different from the one I showed you earlier. Okay, this is a different patient. And I'm going to just show you a few traces. Okay, there's quite a few things going on here. Same patient, but I'm just going to start with trace at the top here. Okay. Okay, tell you what, I'm going to duplicate this. Okay, I'm going to start with the trace of solid. I've actually helped you here because I've put the arrows in. Okay. Tell you what, I'm going to start with the trace in the middle because that's easier. Trace in the middle, okay, because we've just talked about it. So the trace in the middle, does anyone want to tell me what does the trace in the middle show? Chat box, by the way. So this in the middle here, so I'm just going to use my cursor. Can you see this middle here? I've already put down the blue arrows and the red arrows, so it should be quite obvious. Can you see? Yeah, you see the pattern again? What is this pattern? Good, good, okay. Okay, some people put 2 to 1 again. Okay, we need to talk about this 2 to 1 business afterwards. This is not, although it is conducting 2 to, well, it's not really 2 to 1 all the time, isn't it? This is 2 to 1, but this is not 2 to 1. See? So those who are putting 2 to 1 don't use that term. Okay, secondary Mobitz 1 is what I'm looking for, or Wenky back. Okay, this is the same, basically the same thing that you saw earlier. Can you see that the PR interval is prolonging and then there's a drop beat? Here, obviously, there's only 2 beats. Okay, so you can't really see it prolonging. But here you can see it's clearly prolonging again, right? Prolonging and then drop. So this middle segment here shows Wenky back. Okay, right. What about this one here, bottom segment? What does this one show? In a minute. Okay, good. I think most of you got it. Those who put first degree AV block, very good. Yes, you're right. It's got a fixed PR interval, and it's very long, isn't it? It's a very, very long PR interval. It's almost not, well, actually it is. It's actually over 400 milliseconds. It's about 440 actually. It's very, very long PR interval, okay? But it is first degree heart block. So you have P wave followed by QRS complex, P wave followed by QRS complex, P wave followed by QRS. It's first degree heart block. There's a fixed PR interval, but it's very prolonged, okay? And finally, up here, for the purpose of this, because obviously the traces are not so clear, just focus on the 4 beats where I put the P wave in, just the 4 beats where there's a P wave. Okay, what does this show? In fact, if you look at the whole trace, the heart rate is obviously faster, right? But what does this show? Let's just give you another. Okay, some people have put third degree. I don't know where you got that from, but good for trying. I guess what I'm trying to ask you is, I suppose if you look at the PR interval before, which is very long, yes, this is now sinus rhythm with a normal interval. Sinus tachycardia, in fact, fantastic, really good, well done. So as compared to the other traces, which is slower, bradycardic, this one is now sinus tachycardia. Now, I think some of you, I can understand why you might be a little bit confused because the P wave is not very clear throughout all the traces. Sometimes in Halters, you can't see the P wave very clearly sometimes, but it is regular. And where you can see the P wave, you can see very fixed PR interval. And you can see the PR interval, you can see my blue line here, just around 200 milliseconds. So what I want to show in this trace is literally in the same individual, you can have different types of rhythms actually. Okay, don't worry, Tamika, don't worry. Thank you for trying. Don't ever feel the need to apologize. We're all here to learn. So well done for trying. Okay, good. So I was just saying that in this same Halter trace, you can see different types of rhythm. And we'll go through why in a minute, but you can see that, for example, here during the time here is 7:44 in the morning. You can see a sinus tachycardia with a normal PR interval. I presume the patient at the time is up and about, having woken up, maybe making her breakfast, or maybe I don't know what she's doing, but she's clearly doing something involving some kind of activity with an elevated heart rate. Here at 9:28, presumably the patient is resting. And here at 5:11, presumably the patient is sleeping. So you can see that depending on the physiological context, you can have different rhythms. And that's what I was trying to explain to you about this concept of the autonomic nervous system modulating both the SA node activity and the AV node activity. You can see different heart rates, you can see different patterns of AV conduction. And we know that both first degree heart block and Wenckebach, which is second degree Mobitz type 1, are typically modulated by the vagal component of the autonomic nervous system, the slowing down component. And we know that during periods of rest and sleep, such as what you can see here, you can see these findings, okay? Now, another thing that you can do if you wanted to have an assessment to see how much contribution the autonomic nervous system has is to do an exercise. That's another way of doing it, okay? And here I want to show you three traces during exercise, okay? The first is this one, the one you saw earlier with the first degree heart block. You can see the prolonged PR interval, okay? Then we put the patient on a treadmill. You can see the heart rate increasing and increasing, okay? So this is with exercise. And if I put down the 3 stages, you can see, in fact, that there is some shortening of the PR interval with exercise. Can you see that? So this is what I mean by how the autonomic tone can influence AV conduction, all right? So it is worth bearing that in mind. I'll explain why this is important when we talk about how we view bradycardia and how we treat bradycardia. Okay, so just keep that in mind. Right. So tell you what, I'm going to skip that. Okay, so this trace. Okay, this trace I wanted to show you because it's also worth remembering, and I'm just going to zoom in at the bottom now. So it is also worth, if you see patterns which change, it is also worth breaking down the ECG. Okay, can you see that there are three parts to this ECG? Can you see? I've kind of broken it down to three parts. Okay, so I'm going to ask you. So what does the middle part show? What does the middle part show? This part, because that's probably clearer. Okay. Okay. Yes, increasing PR interval. That's right. Yeah. PR interval gradually getting longer. Absolutely. So this is Wenke back, right? Yeah. Secondary movement one. What about this part here? The final part. So this part here is second degree, absolutely. Second degree Mobitz one. Here is first degree, right? This looks like the fixed PR interval. Everyone agree with that? So you can see that the red and the blue and the red looks relatively fixed, yeah? So basically, actually, 1 second. Not quite. Let's have a look. So this one looks fixed. This one looks fixed. Yeah, it is fixed, yeah. It is fixed, yeah. Sorry, this last one you can't see because it's out of the screen. So you can see also that rhythms can change, right? So here it's hard to tell because the 3 beats, there's not enough. Here there appears to be a drop beat, but you can't really tell. So this one is long, this one is longer, this one is dropped. But because there isn't enough trace beforehand, it's very hard to be clear. But I think here is also probably another Wenke back here in front, because here, see, this interval looks shorter than here. So it looks like it's prolonging and dropped. So this is, I think, Wenke back. This is Wenke back, and this is first degree, yeah? Wenke back, first degree, okay? So what I'm trying to show is that obviously we're used to seeing when people give us an ECG, we're used to giving one diagnosis for the whole ECG as well. But it's also worth remembering that rhythms can change as you record it. So sometimes what you have to do when you're looking at heart rhythm, which are particularly complicated, is you need to break it down. You need to break it down and look at the trace and then group them and then see, how, is there any changes in the heart rhythm pattern? So in this case, you can see it flips between Wenke back to first degree. And that fits along with what I was telling you, which is that this is all very likely to be autonomically driven. So when we talk about autonomically driven, so we're talking about the influence on the AV node. So you can have first degree changing over to Wenke back, and it's very commonly seen in halters at night. And when we see this, generally speaking, it's just a function of autonomic function. Okay, so therefore, in these situations, when you see this sort of report, when you see this sort of Halter report, I'm just going back to the original one. When you see this sort of Halter report, where you see nocturnal sinus bradycardia, if you see Wenke back, you just need to bear in mind that what you're seeing may just be an extrinsic cause for the heart rate slowing, may just be due to autonomic tone. It is worth bearing that in mind, okay? And so that's one thing I wanted to show you, and then we're going to then go through these traces now. This one, okay? So what do people think of this trace? Okay. Right, to help you, I think since the first answers are coming back. Okay, I think most of you got this right. Very good. Okay, very good. I think you've all got the answer. So I'm going to just now put the arrows, okay? So this is now, again, putting the blue arrows and the red arrows, the blue arrows being where the P waves are and the red arrows being where the QRS complexes are, okay? So here you can see that, in fact, what's happening is the P waves, the blue arrows, is marching through the QRS complex, okay? So you can see complete dissociation between the atrium and the ventricle. Yeah, so this is complete heart block. So complete dissociation between atrial activity and ventricular activity, complete heart block. All right, good. What about this one? So I'll just give you another minute. Okay, so so some of you have started coming back with the answer. I'm going to now do the same thing. Put the arrows in. I haven't put all of the arrows in, but maybe I should. So while you do that, I'm going to just do some copy and pasting. Okay. Right. Just going to put some copy and pasting. Right. Okay. Does anyone disagree from the complete heart block answer? Because everyone seems to be saying complete heart block. Does anyone disagree? Just going to put all the P waves. The question you have to ask yourself is there any relationship between the P wave and the QRS complex? So, okay, here we are. I think I've got it all now. Okay, good. Okay, yeah, good. All right, so good. I think yeah. So Sabir has said 2-to-1 exactly. So some of you have mentioned earlier on when I was showing some traces. Some of you mentioned. Sorry, I missed one out here. Sorry. Okay. Some of you mentioned 2-to-1 heart block before, and I said no, that's not 2-to-1. This is 2-to-1, right? Because you can see. Ignore the first beat because you can't see the preceding, because the traces is cut off here. So ignore this one. But start from here. Okay, you see 2 P waves to 1 QRS complex, 2 P waves to 1 QRS complex, 2 P waves to 1 QRS complex, 2 P waves to 1 QRS complex. Not just that, the PR interval is fixed when it's conducted. Can you see? These PR intervals are fixed when they're conducted to the QRS complex. Can you see? So this is 2-to-1, or so-called Mobitz type 2. So Mobitz type 2 can sometimes be 2-to-1, can be 3-to-1, can be 4-to-1. Obviously 4-to-1 will be these are all kind of considered. Generally, the heart rate will be very slow in that case, but these are generally considered what we call Mobitz type 2. Okay, the difference, I'm just going to quickly show you. I think this is where people get a bit confused. Right, what is the difference? If you look at the complete heart block again, you can see that in fact there is no relationship. If you look at the PR interval, there is no relationship at all. The PR interval is completely random, because there's no relationship between P and the QRS complex. It's just the P wave is just marching through. If you stand back and look at the trace, you can see in fact there is a regular P wave, and there are regular QRS complex. They are completely dissociated. Okay, so the PR interval is random. Okay, there's no kind of fixed value there. Whereas if you look at something like Mobitz type 2, in this case 2-to-1, you can see there is a pattern. When the P wave is conducted to the QRS complex, that the PR interval is fixed. Can you see? The PR interval is fixed when there is conduction. Okay, and then obviously there are beats which are dropped. How does this differ from type 1 second degree type 1? Well, it's different because remember second degree type 1, you get this clustering effect, and you can see prolongation of the PR interval. You don't see that here. You don't see any clustering. The pattern is consistent. Okay, and the PR interval doesn't change either. Whereas with Mobitz type 1, you get this sort of pattern. I'm just going to show you again. Like this. Okay, you see this sort of prolonged PR interval. In fact, if you look at it, you can see this sort of clustering. It's clustered. Okay, there are beats which are grouped together. So that's how it looks like when you look at all three forms of these heart blocks. Okay, and now back to this diagram again. So I'm going to come back to this diagram that we saw earlier. Now, I told you before that in first degree AV block and in Mobitz type 1 Wenckebach, it's more to do with the autonomic nervous system modulating it. And that's why we're not so worried, because we know that when you have sympathetic predominance, that the conduction will improve. Okay, whereas when you're talking about Mobitz type 2 or complete heart block, Then we're talking about disease below this line. We're talking about infranodal disease, or sort of what we call intrahischian or infrahischian disease. So what we're talking about here is disease either of the bundle of His or further down. And when we have disease either the bundle of His or further down, we're worried because there's a real risk of asystole. We know that people with 2-to-1 AV block, 3-to-1 AV block, Mobitz type 2 type AV block, or complete heart block, effectively, it's the conduction system is no longer working as it should. And these, generally speaking, presents a risk of significant pauses or asystole in the future, which is why we take these as anything below this blue line, which is the mechanism generally of this sort of Mobitz type 2 or complete heart block. We take this as significant heart block, okay? Interestingly, if you were to put these patients on a treadmill when you exercise them, this is what you see. So I'm to give you an example here. So this is another patient with what looks like, some degree of heart block, okay? If you then exercise them, you can see, in fact, that there's dissociation between the P wave and the QRS complex. So when you exercise them, what's happening, in fact, is it accentuates any conduction delay, any conduction block below the level of the node, okay? And it will become more obvious, the level of heart block. And so if you see any of these findings, then we worry about them. And a good guide as to what you do about these bradycardia, generally speaking, when we see bradycardia and heart block, the question we're asking ourselves is this potentially dangerous? Does the patient require pacing? Now here I put down, this is an older guideline, this is from 2013. In fact, there's a newer guidelines from 2021 that is updated on this. So this is no longer the most up-to-date guideline. So please look up the 2021 pacing guidelines. But generally speaking, the advice regarding pacing hasn't really changed, and it's to do with this. If you talk about anyone with, here you can see these are class 1 indication. If you have third or second degree type 2 AV block, irrespective of symptoms, okay, then it's a class 1 indication to pace. So anyone who has got Mobitz type 2 or complete heart block, or so-called third degree AV block, that's an indication to pace, okay? Obviously, here the rest of these things, you can see these are less strong indication. The only indication for sinus node disease is if it's causing symptoms, okay? But you wouldn't do it otherwise. But for AV block, where there's third degree or second degree type 2, irrespective of symptoms, because the risk of asystole, we would give a class 1 recommendation, okay? So that's the point I'm trying to make here. All right, good. So I'm going to stop there. Any questions? It seems to be very quiet there. Anything it's not clear? Anyone wants clarification? Oh, okay. Someone was asking, can we get more talks on rhythms? Yes. So I think I'm doing a couple of more of these. And essentially, I've talked about tachycardia, I've talked about bradycardia. I'll point you out, you should read at the pacing guidelines. I think it is generally useful in terms of management of, it actually talks about management of bradyarrhythmias in general as well. Look at this is the 2013 guidelines, but look at the 2021 one. And some of you might be also interested in how to manage disease spells, transient loss of consciousness. So if you look at the 2021 guidelines, it does give advice about that. It talks to you about how generally assess someone with these symptoms. It talks about the role of things like carotid sinus massage. It talks about things like tilt table testing, which you might be interested in. So all of this, I guess what my angle here is to talk more specifically about the general bradyarrhythmias that you're going to come up with. That next time, and then I've got a final slide with miscellaneous. Can anyone still hear me? Because I think I'm having some connection issues here. Okay. I hope you can still hear me. Can anyone still hear me? Okay, hearing now, good. Okay, sorry about the patchy reception. So in answer to Manisa, so what does you as GP need to stop immediately when 2-to-1 blocks or different types? Okay, the way to think about it is like this, okay? Maybe I haven't made it very clear, so I'm gonna try and make it a bit clearer, okay? So basically, when you are confronted with a patient, you need to decide. So when you're confronted with a patient and you're thinking about treatment, I think about it in two ways, right? The first thing we need to do as doctors is to make sure that if there's anything that's potentially dangerous or potentially life-threatening, then you need to deal with it there and then, okay? So if, I'll give you an example. Let's say someone passes me a trace. Okay, I happen to be sitting in my office doing my paperwork and someone came to me and gave me this trace. Okay, this trace, okay? And I see complete heart block. Okay, I'm going to be very alarmed by this trace, and I'm going to obviously, find out what the symptoms are. And because this trace, because of complete heart block being something that is concerning, that there is a risk of asystole, obviously I'm going to act a lot quicker. And the imperative, the sort of thought process is: does this patient need pacing? And when should it be pacing? So in general, if you're a GP and you see this sort of ECG, you need to escalate immediately, right? You need to, the patient's at home, you need to get the patient to go to the hospital because they need quick assessment to see whether or not, they need to be somewhere safe. And we need to think about pacing these patients, right? Because there's what we call a potential prognostic indication here. Prognostic indication just means that anything which may be potentially dangerous, where a treatment will help increase life expectancy and prevent premature death. Okay, so complete heart block and Mobitz type 2 heart block falls into that category. Now, the other types of heart block, let's say first degree heart block or Wenckebach, Mobitz type 1, those are generally autonomically mediated, generally speaking, and generally speaking are not as concerning. Okay, they don't tend to by themselves mean that there's anything significantly wrong. Because as you saw from the Holter monitor, these things can just flip around depending on the autonomic tone. You put them on a treadmill, they normalize. So in these patients, you're more relaxed about it. You're not so worried that their heart's going to stop. So in those situations, really treatment depends on whether you think the symptoms are caused by bradyarrhythmia. It really depends if the symptoms are causing bradyarrhythmia. Sorry, the symptoms are caused by bradyarrhythmia. So whether the bradyarrhythmia are causing symptoms. So if there is, say, significant bradycardia that's causing symptoms, we can also consider more definitive treatment like pacing. But as you can see, if you look at the guidance, here, sinus node disease, it's only indicated where symptoms can clearly be attributed to bradycardia. That's the only time. If you look down here, sinus node disease, you could consider it even if evidence is not conclusive, but it's a 2B. 2B means we're not really, our recommendation isn't so strong anymore. And here, see here, sinus node disease, pacing is not indicated when sinus bradycardia is not related to symptoms or due to reversible causes. So you can see that just because you see nocturnal sinus bradycardia, and I know this happens a lot because I see a lot of people get Holter monitors, we always find nocturnal sinus bradycardia because that's normal. If it's not contributing to symptoms, then it doesn't mean anything. Class 3 means don't pace. It doesn't have any treatment implications. So things which are things like sinus bradycardia or Mobitz type 1, unless there's a clear relationship to symptoms, they don't need treatment. What is this? Oh, congenital heart disease, pathophysiologic sinus bradycardia, and pathologic sinus bradycardia. It's very hard to say whether sinus bradycardia is pathological or not because everyone's resting heart rate can be different. It's more useful to say, clearly, someone who has got, say, congenital heart disease or perhaps a history of atrial fibrillation, they can have something called sick sinus syndrome, okay? So that the kind of sinus node disease in those contexts may take on a different complexion. I think if you have sinus node disease with something else that worries you, then always seek an expert opinion. That's what I would say. Okay. So okay to go on propranolol of ECG first degree in a young person. The question you have to ask yourself is why is the person going on propranolol, right? You know, if you're going to put someone on beta blocker, that may prolong the PR interval. It may make first degree heart block more prominent. You know, if you're really going to start it, I generally would say whenever you start a treatment, it's always important to be sure why you're starting it and whether the side effects or the risk is proportionate. You know, if you're going to start propranolol for anxiety, there are other ways of managing anxiety, to be honest, in my opinion. You know, always be mindful. If you're going to start a medication and you think it might be causing side effects, then monitor carefully and tell the patient carefully what the potential side effects are. Because what you may be doing is you may be swapping one set of symptoms for another set of symptoms. Autonomic influence with right and left bundle branch block. That's a very good question. No, generally speaking, the autonomic tone, when we're talking about, so I've drawn a line here, if you can see. I've got to draw, that's my line here. Okay, so I've drawn a line here. Anything above this line, so SA node and AV node, that tends to be affected by autonomic tone. Anything below that line, so the bundle of His and the Purkinje system, including the fascicles, so the right and left bundle you're saying, those don't tend to have such an effect. The autonomic tone doesn't tend to affect it very much. So if you have got bundle branch block, then that tends to be something that is, you know, more to do with fibrosis or some kind of conduction disorder rather than autonomic tone. Right, okay. I think we're coming up to 3 o'clock. Oh, common causes of high degree heart block that you need to be aware of. I think the usual things, really. I think you clearly probably know about surgical sieve. So, you know, when you talk about etiologies, always start from things like, you know, could be medication, so iatrogenic, could be ischemic, could be fibrosis. Actually, fibrosis is another kind of common reason. And in younger people, you know, that's why young people with heart blocks, with significant heart blocks, patients that come through my clinic generally get an MRI scan because they could be underlying fibrosis of the heart. In the case of causing heart block, that means the fibrosis is affecting the septum. It's affecting the conduction tissues, the fascicles. So, you know, we would, at very least, they should have an echo. But a lot of these patients, if they have got significant heart blocks, I tend to do an MRI because there could be some latent myocarditic process or fibrotic cardiomyopathic process that's happening. So those are the kind of common things. Obviously, other kind of reversible causes, we'll talk about reversible causes. Temperature, hypothermia can cause profound bradycardia and heart block. Obviously, sort of hypokalemias, magnesium, those things. But they tend to be fairly, you have to have fairly deranged electrolytes to get this sort of phenomenon. Those are the main ones really to talk about. Okay, it's now 3 o'clock. I'm going to draw this to a close. Thank you for your attention. I hope you found it useful. As always, do give feedback, and I apologize for the some issues with the connections today. Okay,